And look also at the signal, the T2 weighted, the T2 water signal in a normal human disc. And this is the normal T2 weighted water signal in the dog. And here we have a black disc, and here we also have a black disc with bulging. So very similar if you look at it from that perspective. So what are we talking about in dogs? Well, in dogs we are talking about degenerative lumbosacral stenosis, and this disease has also received different names in the literature. It's a very analogous situation with the cervical myelopathy. These two diseases have a lot in common, but they're just in another part of the spine. And here we are talking about the lumbosacral spine. So we see instability with this disease. We see type 2 disc herniation, just like in disc-associated cervical myelopathy. We see osteoarthrosis of facet joints, spondylosis, and there's also a congenital stenosis of the lumbosacral spine that leads to symptoms in dogs that are quite young, at 1 or 2 years of age. And we have sacral osteochondrosis that also contributes to low back pain in young dogs. In general, we call this disease degenerative lumbosacral stenosis. If you look into the literature for humans, you may find lumbosacral stenosis, you may find disc herniation, or in general low back pain. A lot of literature in humans you will find with searching for low back pain. And generally we have a combination of type 2 disc protrusion, stenosis, instability, and a lot of degenerative changes of bone structures and ligaments. And this all contributes to compression of the chordae equina. And the chordae equina is located at L6, L7 or L7, S1 in the dog. So at both junctions you may get the same clinical features. Now, traditionally, we have looked at low back pain in dogs from a compression side view. So we thought, okay, if you have something compressing on the chordae equina, this results in pain. This is very logical. And compression of neural structures, we know, will cause inflammation, focal inflammation, very localized. And if you put compression on a root that goes to the hind limb, you will get root pain. However, what we don't really realize in dogs is that already in the early stages of degeneration of a disc, it may get painful. And there's no compression, and there's no involvement of the root, but there may be disc degeneration going on, and this may lead already to pain. And this is what we call discogenic pain. And this is a well-known feature in humans, but it's very difficult for us as veterinarians to say this dog has discogenic pain. The diagnosis in humans of discogenic pain is also not so easy. So traditionally we have looked at the origin of low back pain from the disc, difficult to diagnose, or from compression. If we have something compressing on the neural structures, it may get inflamed, that will cause pain, and especially if it affects a root that goes to the hind limb or even to the forelimb. If we look now in the literature on low back pain in humans, there's a lot of information there that also tells about other structures that are involved in this pain syndrome. And certainly compression only partially explains low back pain in humans. We got inflammation of neural tissue, ligaments, the facet joints are involved in humans in low back pain, discogenic pain, even end plates, little fissures in the end plate may contribute to low back pain, and even the vertebrae themselves. And I'll talk about this at the end of the lecture. So the discogenic pain that's quite a weird situation where people are complaining about low back pain and they go to their physician and they get medication, may work, may not work, they go to the physiotherapist, may work, may not work, they come back to the doctor, still have low back pain, they send for an MRI, and the MRI does not show any compression. And people still have low back pain. So then they may get a diagnostic test for discogenic pain. And this diagnostic test is that the physician injects under local anesthesia, the skin is locally anesthetized, and injects saline water into the disc. And if then people start to yell when they inject a certain volume in the disc, then this is diagnosed as discogenic pain. So what the theory behind it is that not the discogenic pain is originating from tiny little nerve fibers in the annulus fibrosus. So if we look at the canine disc, this is the normal situation. So we have the disc, the annulus, the nucleus, the dorsal longitudinal ligament here. We've got the chorda equina, and this is the ligamentum flavum and the facet joints. And now if we think about degeneration, it usually starts in these dogs in the nucleus and in the annulus. And already at this stage it may be painful, but for us very difficult to diagnose, because if we do imaging we may not see any major changes, we may not see any compression, and the test that is done in humans cannot be done in dogs. I mean, you cannot inject in an awake dog something into the disc, so you need to put them under anesthesia, then you can do the test, but then they cannot respond. In humans, this is done by the awake patient, and the response of humans is the diagnostic test. But it cannot be done in dogs. But what we do know in dogs is that this may continue into protrusion, and it pushes up the chorda equina against the roof of the sacrum. You can see that here, and the nerves get irritated. And especially if the dog starts to extend its back. If it extends its back, and the sacral roof comes down, and you get a worsening of the compression. And that's why these dogs do not want to extend their back when they have low back pain. If the protrusion is to one side, if it is not central but lateralized protrusion, then this may irritate these nerves that go directly to the sciatic nerve, to the hind limb, and you may get root pain. We call this the referred sciatic pain. It's called the root signature. And again, with compression, with extension, we get dynamic compression and worsening of the symptoms. So, and I'll talk a little bit more on that in the next presentation. So then we'll talk a little bit about the clinical features of low back pain. But this talk will focus on conservative management and the role of disc injections. So the conservative management of low back pain in dogs is actually the same as for joint pain. So we have the same scheme that we use for dogs with arthrosis, osteoarthritis, as in dogs with low back pain. And you can see low back pain as the arthrosis of the spine. So we give information on controlled exercises, develop a daily routine for owners with their pets. We advise them to avoid high energy exercises. In the case of working dogs, you should adjust the work for the dog, reduction of body weight if that is the case, and physiotherapy or hydrotherapy. So you need to do a little bit of client education. You need to tell owners how to deal with their pets. You also need to tell them that usually degenerative changes of the spine cannot be cured. That is something that is there, and it may get worse over the years, but it cannot be cured. The only thing that we want to do is we want to stop or slow down progression of the disease, and we want to reduce the clinical signs. That is the aim of our conservative management. So, and that is done by exercising to maintain muscle mass, correction of overweight, and medical management with numerous drugs. So if they go to walk at the sea, we advise them go and walk on this firm surface here and not in the loose sand, because that takes a lot of energy from the dog, and this is high stress for the dog on the low back, so they should not do that. And if they are going to swim, do not have them come out of the water like this. This will put a high stress on the low back. And then if the dog is overweight, we advise them to reduce intake and to exercise. It's very simple, and we do that every time for the joints, for arthrosis. We should also do that for low back pain. And then how about medication? And you can talk for an hour on medication, but it's the basis of the medication is dealing with the inflammation. The inflammation that plays a role in degenerative joint disease, but also in low back pain. And when you are dealing with medication, it is wise to know what you are treating actually. So the pain that comes from dogs with low back pain is essentially the same pain that comes from degenerated joints. It all is about inflammation and about cytokines that are released in the joint space or the disc space or around nerve roots. And cytokines and prostaglandins play a major role in this, that they irritate or they attach to the nociceptors in the joint or in the disc. And that is the cause of the pain. So in joints, these prostaglandins are released in the joint fluid, and then they attach to the nociceptors, and that's why dogs, but also humans, feel pain. And it all is taking part in the cell membranes of the synovial lining, or in the disc, or around membranes around the nerves. And the main pathway that is involved in that is the arachidonic pathway. And I'm sure you're familiar with this pathway. It's a pathway that involves arachidonic acid here at the top, and then enzymes, the cyclooxygenase enzymes, which transforms the arachidonic acid into prostaglandins. And these prostaglandins lead to the prostaglandin E2, PGE2. And the PGE2 is the central stimulator for pain. So this pathway ends up in the PGE2s, and these PGE2s are the main stimulators for pain in degenerative joint disease and in low back pain. So if we give steroids, we inhibit these enzymes, which will end up with lower dosages of, which will decrease the production of PGE2. And the NSAIDs, the non-steroidal anti-inflammatory drug, they inhibit these enzymes, the COX enzymes, which will also lead to less PGE2. Now the COX enzymes are everywhere in the body. We have the COX-1 enzymes, we have the COX-2 enzymes. And the COX-1 enzymes are actually the good COX enzymes. So we do not want to inhibit these enzymes, the COX-1. We only want to inhibit the COX-2 that are involved in this pathway, in this pain pathway. And that's why you see all these selective COX-2 antagonists on the market, the selective COX-2 inhibitors. And there are many out there for us as veterinarians. So there's a whole bunch of them in Europe. I'm sure they are also available in Russia. We have Metacam, we have Previcox, we have Rimadyl, and the patent has expired on Rimadyl, so everybody is copying it. Carparol, Carprodil, etc., etc. It's all the same stuff. It's all Carprofen. And these companies put that on the market. And these are the NSAIDs that deal with this pain pathway, which centers around PGE2. Here I made another table. Aspirin is also a COX-2 antagonist. Ketoprofen is not used anymore, really in the Netherlands. Tepoxylin is not on the market anymore. And Verocoxib is still on the market, Previcox. So this differs in time, and there will be a new one, and one will go away. But essentially, these are all COX-2 inhibitors. The difference is in their selectivity for the COX-2 enzyme. And they can be combined with other medication. So we combine NSAIDs with other medication that work by another pathway. And so we have the opioid pathway, and for that we can give tramadol or tramagetic. So these are more morphine-like substances. And we have Symetrel and gabapentin, which deals more with the neuropathic pain. And I'm not an expert in pharmacology. I cannot tell you exactly how they work. The opioids are, that's clear, that's the opioid pathway. Gabapentin is more focused on inflammation around nerves, so also works on the PGE2, but more than involved in neuritis. And if we continue with NSAIDs for a long time, so this is specifically for NSAIDs, then we combine it also with omeprazole to protect the stomach and the intestines for the side effects of NSAIDs. So these are the dosages for tramadol and tramagetic. Tramadol has a wide range of dosage. Look at the range, 1 to 4 milligrams per kilogram, 2 to 4 times daily. So you can actually go in all directions with tramadol. and also traumatic. This is a human, actually these are human substances or human medications that can be used for dogs. Traumatic once daily it's called, but in dogs it's given twice daily. Don't ask me why, but this is what our anesthesiologist tells us to do. And then we have steroids, of course. And very important is that steroids should not be combined with NSAIDs. If you do that, you run the risk in more complications with NSAIDs or steroids. More GI bleeding, more vomiting, more side effects. So it's either NSAIDs or steroids. And steroids are maybe a little bit more effective, but they do essentially the same as NSAIDs. So we can use prednisolone, dexamethasone. These are the dosages. And then there's a steroid that we can also inject in a joint space or in the epidural space. So here is summary for now. In Utrecht, this is what we give for low back pain. We start with NSAIDs. One NSAID. I don't mind which one. The best that the dog is managed with, or that the owner is happy with. And then we can add tramadol or gabapentin. And if that doesn't work, we can even add amantadine, which is Symmetra. And some of these dogs are managed on 3 or 4 medications to get them pain-free. The most common combination is the NSAIDs with tramadol and gabapentin. That's the most common. I think it's quite rare that we have to add a 4th medication to that. But it already tells you that some of these low back pains can be quite nasty in that they are not really managed, but with only NSAIDs. Or the dog cannot take NSAIDs because of vomiting or GI bleeding. So we have to stop the NSAIDs and then we go with tramadol or gabapentin. So the do's and don'ts of medical management. So we try to optimize the effect of NSAIDs with tramadol or gabapentin, Symmetra. We do not combine NSAIDs and corticosteroids because of the risk of side effects. And if you use steroids for a long time, remember that you also will inhibit the natural cure that takes place in joint disease or in disc disease. You will inhibit natural cure, you will inhibit the immune response of the dog. And this is already done by 1 week of steroid medication or by 1 injection. You will completely shut down the pituitary adrenal axis with steroids. So if you treat with 1 month or 2 months, you will cause iatrogenic Cushing's in this dog, and then you have another problem. So that is also why we are cautious using epidural injections with steroids. We do that to a maximum of 3 times. And then I'm just showing you this slide. At this moment, I think February, March, in Europe at least, a new medication will be launched for the veterinary use, for the veterinary market. It's called Galliprant. And Galliprant is not a COX-2 antagonist. It works a stage lower in the cascade, in the arachidonic exit pathway. So it will antagonize the EP4 receptor. And the EP4 receptor is the receptor that is involved in the PGE2 release. So So you can see here PEG2. I've told you PEG2 is the bad guy in the prostaglandins. This will cause the pain. And this will go to a receptor, the EP4 receptor, and this is blocked by galiprant. So you may ask yourself, why do they put this on the market? Because we have COX inhibitors, we have steroids. Well, these NSAIDs and the steroids, they have all these side effects. This, at least that's what the company tells us, this EP4 antagonist doesn't have the side effects of the NSAIDs and the corticosteroids. So we'll see, it comes to the market. It is FDA approved for, so it's on the market already in the States, in the United States. And the company, I think it's Elanco, has done 1 year's preparation in Europe to get it on the market. And the dosage is 2 milligrams per kilogram, once daily, so that's nice. Only once daily tablets are needed. And it should not be given with a meal. So that's different than with NSAIDs. The field trials and the pharmacological studies have shown that if you give it with a meal, it is less effective. So this is different from many medications that we give. Should not be given with a meal. It's FDA approved for canine osteoarthritis, but since low back pain and osteoarthritis are very close to each other, I think this can also be used for low back pain. And certainly we will start using it as soon as it is available and see how that works out. So let's go to the injections. I already mentioned epidural injections. What we tend to use is methylprednisolone, which comes in this in the Modarin injections. The brand name is called Modarin. Dosage is 1 milligram per kilogram, and the injection is given every 3 weeks. One complete cycle consists of 3 injections. I have not had a dog yet that needs more than 3 injections, or that I would advise to use more than 3 injections. Either they use 1 and it works nicely, and then I may repeat it a second time or a third time, or 1 injection doesn't work and then I stop. If it does work a little bit, I may give a second or a third injection. We select the patients for that, so we don't give it to all patients with low back pain. We stratify the patients to the injection, so we tend to use the dogs with no compression on the MRI scan, or moderate compression, or young dogs, or very old dogs, or owners that are not willing for surgery. So we stratify patients to the epidural injection. And especially when MRI shows thickened nerve roots and not so much compression. So many times we see that they do not go hand in hand. We may have a thickened nerve, but not a lot of compression. I think these are good candidates for epidural injection. So the landmarks for epidural injection in the lumbosacral area is the spinous process of L6, which is cranial to the tubercocci. So these marks the tubercocci in red. And then we have the spinous process of L7, which is usually tends to be right between the tubercocci. And then this is the sacral crest. And here you can see from the side that L7 is usually at the same level as tubercocci. And the first big process that you can palpate, especially if the dog is a little bit overweight, then palpation is not so easy. But the first big process, spinal process that you can palpate here is usually that one of L6. And the injection is centered between L7 and the sacral crest. So, and what is important is that we flex the hind limbs forward. So by flexing the hind limbs forwards, we open the epidural space here, or we open the I should say the natural opening between the lamina of L7 and the lamina of S1. So in a neutral position, this is your opening, your window for your injection. If you now flex the hind limbs forward, you put the dog in hyperflexion with its hind limbs on the table, then you open this window. So then it's easier for your needle to enter the epidural space. So the hind limbs should extend cranially, and by that you do ventral hyperflexion of the low back, and this opens the window for your needle. So this is just an example. This was a French bulldog with low back pain. I'm right-handed, so I do the injection with my right hand, and my left hand palpates the landmarks. So if you are experienced with this technique, you don't need imaging for that. It's quite a precise technique. It is easy, of course, to use imaging, but it's not really necessary because you can nicely orient yourself on the landmarks. So here I palpate tubercocci, I palpate L7 spinous process. I work with gloves, so this is a spinal injection, so you need to take aseptic procedures. We put a little drape around it, we prepare our medication. So this is the Moderin, the prednisolone.